Hello, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are the Oncology Brothers. Today, we're excited to have a fellow Canadian who's also a friend and famously known as one of the two onc docs, Dr. Karine Tawagi, a medical oncologist, and then a nationally renowned researcher and a urologist, Dr. Sia Daneshmand from Southern California, to discuss their approach in treating bladder cancer using an algorithm and to reiterate the current standard of care treatment options. Karine and Sia, thank you so much for joining us.
Thank you. Pleasure to be here.
So, as we were starting off with just covering the entire bladder cancer, you have to teach us in 15 minutes. Starting off, Sia, with non-muscle invasive bladder cancer, urologists here play a huge role where we have BCG, which we have been utilizing for years. Now, recently, we have data on pembrolizumab and a vaccine. Sia, if you don't mind going over your approach here in early stage or non-muscle invasive.
Yeah, thanks. It's a large topic to cover, but I'll try to do it some justice here. So yeah, as you have it right there, I think the most important is categorizing this between low grade and high grade, or what we call the AUA risk categories. Typically, the low grade tumors are not ones we are concerned about progression, but we're certainly concerned about recurrence. And so for the most part, they're undergoing cystoscopic surveillance. Occasionally, we do use some intravesical chemotherapy. We try to not to use BCG in this setting because of the national shortage and the fact that low-grade tumors are really not all that responsive to BCG anyway. So if anything, intravesical chemotherapy for bladder, for the low-grade tumors, if they're recurrent, then they become this intermediate risk category. And we do have a number of clinical trials right now investigating a number of agents that hopefully will reduce the recurrence rates. And again, we're not so concerned about progression in those patients because that tends to be less than 10% usually. The high-grade ones are the ones that are worrisome, right? Those are the ones we are concerned about, not just recurrence, but also progression to higher stages and potentially even muscle invasive disease, as 20 to 25% of these can progress to muscle invasive disease. So the mainstay of therapy for that would be BCG still after 40 years. But things may change a little bit in the future. Again, we're having a major national shortage right now of intravesical BCG. So other agents are being tested in this setting to see if we can replace BCG or at least alternate and be able to use some other form of intravesical therapy. So I like how you have this represented here. I think this is sort of from a sort of 30,000 foot square a view of this. This would be how we manage it. I see up there you have nadofaragene firadenovec, which is the newest agent that was approved for BCG refractory CIS plus minus papillary disease. That was just approved actually last year, but became available first to a select few centers in the U.S. in October, and then widely available as of January 17th. So that is in our armamentarium right now. That's known as Adstiladrin. Again, nadofaragene firadenovec, first gene therapy to be used for bladder cancer. Pembrolizumab does have a role for BCG refractory CIS as well. That was the first agent that was approved in 2020. And that is, again, used for BCG refractory CIS plus or minus papillary disease. The only issue is you guys are very familiar with Pembro. Obviously, you use it in so many different disease states, cancers. And the issue is, we are dealing with a non-muscle invasive bladder cancer, and the use of checkpoint inhibitors in this setting does give us a little bit of a pause, given the potential for life-threatening side effects, or life-altering at least side effects, where as urologists we're used to just keep treating with patients with intravesical therapy. So radical cystectomy always remains as the sort of gold standard option for BCG refractory disease, but that's being utilized less and less as we have more and more options for patients who have not progressed to invasive disease.
Absolutely. Thank you, Sia. A few things to reiterate that the bulk of our patients, when diagnosed with bladder cancer, indeed have an early stage cancer. And it's also important to appreciate the extent of the disease. It is important for us to have adequate sample or biopsy to make that decision saying, is this indeed muscle invasive or non-muscle invasive? If not, then Karine's going to jump on and would remind that the board exam answer here is to repeat the biopsy. Karine, since 2020, Sia alluded to this, pembrolizumab has been approved for high-risk non-muscle invasive bladder cancer that's not responsive to BCG. We have other options available as well. Have you noted a lot more referral to medical oncologists in the community or in academic centers because of this approval?
Yes, definitely. I think, but Sia brought up some good points. First of all, it's 2 years of therapy, not just 1 year. And then second of all, the toxicities that could be lifelong from immunotherapy are not to be discarded. So I think there were about 10-ish% or so of patients that got pembrolizumab that had grade 3 or 4 toxicity from immunotherapy. So I think that's definitely something to consider, but I do think we are seeing more of these non-muscle invasives in our medical oncology clinic. And, with some of the new treatments that are coming out, we may continue to see more of these patients as well.
Another option that Sia, you did mention was cystectomy, though a lot of our patients don't tend to rely on that because of the quality of life issues associated with it. Now, we also, in the era of BCG refractory or BCG shortage, we have the option of gemcitabine, erdafitinib, intravesical. Sia, you have been very much involved with the phase 1 trials of it. We'll have to see how it all pans out, but certainly an option for future itself. Now, looking at muscle-invasive bladder cancer, where medical oncologist plays a huge role here. Karine, your approach here, particularly for cisplatin-eligible versus cisplatin-ineligible patients.
Yeah, absolutely. So I think most of the time these patients are, of course, seen by urology first, and they'll have, a resection of the bladder tumor. And then if there's found to be muscle invasion, then they will be properly staged and then referred to medical oncology for consideration of chemotherapy prior to cystectomy if they're eligible, or consideration of chemoradiation if they're also a candidate for that. So I think the categories that you have here, so cystectomy eligible, you can go into cisplatin eligible versus cisplatin ineligible. And so for cisplatin eligible, we know that there is a defined role for neoadjuvant chemotherapy, and those options are gemcitabine cisplatin, as well as Gosain MVAC. And so I think in the community and at academic centers, I think gemcitabine cisplatin is the most commonly used regimen, and that's given every 3 weeks, usually for 4 cycles. But if there are positive lymph nodes, maybe providers will choose to go up to 6 cycles. For younger fit patients, you can consider Gosain MVAC. The Vesper trial released its final overall survival a few months ago, and there was a benefit of using this regimen. It does include an anthracycline, so you have to be more wary of cardiotoxicity and things like that. And that's given every 2 weeks, up to 6 cycles as well. And then for those patients that qualify for cisplatin, then they can get the neoadjuvant chemotherapy, then go for cystectomy. Even for patients that are cystectomy eligible, you can consider bladder preservation if they meet the criteria. So I think that if a patient meets the criteria for bladder preservation, they really should still be offered both options. And so criteria for bladder preservation or concurrent chemoradiation include smaller tumors, usually under 5 centimeters, although some radiation oncologists may be more comfortable at a higher size. If they can have maximal resection by the urologist of the primary tumor, if they have adequate bladder function and no hydronephrosis, as well as no CIS. And so oftentimes when we see those patients after they're referred from urology, we consider if they're eligible for both options or not. Another thing I wanted to mention for cisplatin eligibility is noting if they have hearing loss, if they have pre-existing neuropathy, if they have renal dysfunction, usually a GFR cutoff of 50 or so is our cutoff for cisplatin, whether they have heart issues, and what their performance status is. And so for some more elderly patients, they may not be eligible based on frailty. And then for cisplatin ineligible, we know that there's no defined role for neoadjuvant chemotherapy. And so that's where patients go to cystectomy right away. So I think if you're looking at this algorithm here, for cystectomy eligible that are cisplatin ineligible, then you can fall into the secondary category of cystectomy. And then we'll finish for the cystectomy eligible. For those patients, we know that if they have residual disease after the cystectomy and they've had neoadjuvant chemotherapy, meaning they were cisplatin eligible, there is a role for nivolumab immunotherapy for 1 year after the cystectomy if there is still residual muscle invasive disease at the time of surgery. And so that's T2 or greater, or if they have positive lymph nodes. That's based on the Checkmate 274. We don't have overall survival data for nivolumab. So I think, again, it's a risk-benefit discussion. There can be some long-term toxicities from immunotherapy that we need to be aware of. There also was the Ambassador trial that presented recently, pembrolizumab in the adjuvant setting, which also didn't have overall survival benefit. It's not FDA approved, so I think we can leave nivolumab on there for the point of this discussion. And then for patients that did not receive neoadjuvant chemotherapy, going to the second arm here, that undergo cystectomy, you can consider giving them adjuvant chemo if they're eligible for cisplatin. But really, those patients that are eligible for cisplatin should have received it in the neoadjuvant setting. And then if they were not eligible, you can consider adjuvant nivolumab. So in the second arm of muscle invasive for patients that are cystectomy ineligible, or the caveat that I would add is patients that are cystectomy eligible but prefer to keep their bladder, you can do chemotherapy with concurrent radiation. And I mentioned some of the eligibility criteria. Those regimens are often 5-FU with mitomycin C. It's about a 5-week regimen. You can also consider gemcitabine alone. You can consider cisplatin alone. There have also been some, especially in COVID times, providers that gave capecitabine as a sensitizer to have an oral option. But I think that for patients that want to keep their bladder, we know that there is a quality of life benefit for patients that do keep their bladder. And so that should be considered for patients that are eligible. The caveat is that, of course, keeping your bladder, you have a higher chance of local recurrence. For some patients, they may not be eligible. And if they have to be compliant with cystoscopies as part of the surveillance moving forward.
Yeah, just to add to that, approximately 30% of patients are ideal candidates for chemoradiation. So it's not for everyone. You do have to consider that if they fail, about 15 to 20% will move on to cystectomy as a salvage option, and they may not be eligible for a neobladder at that point, having had radiation in the pelvis. So things to consider, that there is a 15-20% failure rate with chemoradiation. And as Karine mentioned, there are a lot of non-muscle invasive recurrences, which means more intravesical treatments in a radiated bladder that may be poorly tolerated. So I think Karine mentioned in the beginning, good bladder function. I can't stress the importance of that, because if you've got a bad bladder already that's low capacity, low compliance, irradiating it is going to make it even worse. So
yeah, there's a lot that's happening here. So Karine, thank you for walking us through so elegantly. One thing I want to mention, that in the community, the usage of cisplatin has been a lot lower than what it is in academic centers. And the reason why I want to bring that up is carboplatin in neoadjuvant settings is subpar. And we can consider split cisplatin dosing in certain patients if need be. If we are doing that, Karine, what does split cisplatin look like? Like, what does that infusion regimen looks like in your clinic today?
So then you get this cisplatin instead of on just day 1 of the 21-day cycle, you get it on day 1 and day 8 at a lower dose of 37.5. And I actually consider that for a lot of patients that, you know, maybe have more of the borderline cisplatin eligibility features. But I think to your point, yes, carboplatin in the neoadjuvant setting is inferior, and we really need to advocate for patients to be considered for neoadjuvant treatment if they qualify in the community prior to cystectomy.
Absolutely.
Yeah, I can't stress this enough myself, that carbo really has very limited role in non-metastatic disease and bladder cancer. I would say not even limited, has no role. And so it should not be used in the neoadjuvant or adjuvant space in bladder cancer. The only indication for it would be a cis-ineligible patient Now with EV Pembro, I think that's been supplanted as well. So I see a lot of people sort of starting out with cis and going to carbo after they're not interchangeable. They should not be used in that setting, as Karine said.
Thank you.
Now, talking about metastatic disease, based on ESMO 2023, we saw the standard of care change, in fact, where we used to be using cisplatin if patient is cisplatin eligible or relying on carboplatin-based regimen. Now, after EV302 showing doubling of overall survival with EV Pembro, rightly so, Dr. Powell's got standing ovation for this. Karine, your approach in this setting here.
Yeah, I think that was really exciting. It completely changed the landscape of advanced or metastatic bladder cancer. And so I think based on EV302 data from ESMO, I think everyone's first line standard really should be enfortumab, pembrolizumab. As you mentioned, there was doubling of the overall survival and doubling of the progression-free survival. About 30% of patients had a complete response, which is amazing. And 70% of total patients had a response. And so I think most patients are going to be candidates for enfortumab and pembrolizumab. A few caveats are if you have uncontrolled diabetes, if you have cirrhosis or Child-Pugh B or greater, there's maybe a bit more concern for toxicity. If you have pre-existing neuropathy, which enfortumab can worsen neuropathy, but of course cisplatin can also worsen neuropathy. So in general, I think that this is our new really exciting standard of care in the first line setting. I think that maybe in the community also there's less of a defined roles of how to manage toxicities from antibody drug conjugates. And this is going to be really an evolving paradigm that we're going to have to be really conscientious of, because we had that with immunotherapy where there was all these new toxicities that we have to learn how to manage. And I think the same now is true for these antibody drug conjugates. We do want patients to get what is now considered to be the best standard of care, both at academic centers and in the community, but also to be comfortable with managing these toxicities. And as a group, we have to do better in terms of defining these managements for these toxicities. So I think that for most patients, that will definitely be the standard. I think what to do in the second line setting after EV Pembro is a very big question mark. So there, in the protocol, we don't have the full paper out from EV302, but there were some patients that got chemo after EV Pembro. So I think you can consider platinum-based chemotherapy. I think one of the concerns, again, is if they have neuropathy from the enfortumab, are they going to be eligible for cisplatin? Are they going to be eligible for chemo at all after progression or toxicity on EV Pembro? I don't know that there's going to be a huge role for dose-dense MVAC in the second line setting. And then if they do qualify for chemo, what are their response rates going to be? Are we going to expect the same kind of response rates as we saw in the first line setting, which was in the 40% range? And then if they do get chemo, is there a role for maintenance avelumab or immunotherapy? And so I know we've seen in kidney cancer, for example, that rechallenging with immunotherapy did not have good efficacy. So I think that it's quite possible that the same will be the case in bladder cancer. And there are going to be trials looking at what to do in that second line setting post-EV Pembro. Unfortunately, I don't think we're going to have a comparative trial where it's going to be chemo versus sacituzumab versus these FGFR agents. So really, we're going to be plagued with comparing individual trials to decide what to do in the post-EV Pembro setting. And so I think for patients that are chemo eligible, I would consider chemo in the post-EV Pembro setting. I would also send for next generation sequencing, and if they have FGFR3 mutations, I would consider erdafitinib in this setting. And then in terms of sacituzumab, it has been approved in the post-chemotherapy, post-immunotherapy setting. It had response rates in the 20% range. And so how is that going to perform after EV Pembro? It's another antibody drug conjugate that has different toxicities from enfortumab. So theoretically, it could be well tolerated. There are ongoing trials looking at it in this setting. And so I think that could also be an option. But I think this will be an evolving field for sure in the next few years.
Okay, wow, there's a lot to unpack here. This is great. Dialing this back a little to EV Pembro. Karine, you mentioned 30% complete response. I would love to see ctDNA playing a bigger role in defining complete response. But Sia, any role of radical cystectomy in those selected fit patients that got complete response?
Yeah, it's a great question, and I don't think we've quite we don't know the answer. There are some patients who go on to EV Pembro for locally advanced disease. That this includes pelvic lymph nodes. And so we're seeing some spectacular responses in those patients, but they may have some disease in the bladder. We've selectively taken patients to the OR and seen some actual CRs with EV Pembro where the imaging didn't quite show us what we thought was a CR. So I think it's an evolving field, and I'm not sure what the role of cystectomy will be in some of these patients, but certainly the ones who have residual disease in the bladder and have responded in the lymph nodes, I think there will be a role. And to your point, I think ctDNA will play an important role in determining whether we should be taking these patients. If their ctDNA is positive, they probably have some element of systemic disease, and maybe we shouldn't be doing localized either radiation or cystectomy, whereas the ones who are ctDNA negative, perhaps are the best candidates for moving on to localized therapy. So evolving field.
And again, we have new options in community. We need to start to get comfortable in managing some of these side effects. Karine, for enfortumab, you've mentioned peripheral neuropathy, diabetes. We have to keep an eye out for skin reactions with sacituzumab. We've used this in breast cancer as well. Something to be mindful about is diarrhea, neutropenia. And then I have a patient who's actively on erdafitinib. Keeping phosphate abnormalities is important. Karine, any clinical pearls around these agents in managing their toxicity?
I think for enfortumab, dose reductions are very common, specifically for neuropathy or even for the skin toxicity. So that frequently happens. I think for patients that have a response, some providers are choosing to drop the enfortumab if they get to that complete response. Let's say there's not a defined period, but maybe you can use ctDNA to support, let's say, at 6 months or 9 months or a year, they have a response. Maybe you just keep them on pembrolizumab. I think, for the skin toxicity, topical steroids and antihistamines and things like that. I think for sacituzumab, it's important to consider primary GCSF prophylaxis. There was actually a retrospective study at ASCO that looked at patients that got GCSF prophylaxis with sacituzumab, if you can get it approved by insurance, and there was no severe neutropenia for those patients. And, I think for erdafitinib, to your point, the phosphate binders is a big thing as well. And then having a good rapport with specialty services, there's rarely ocular toxicity with enfortumab or even with erdafitinib. So it can be common.
And the nail toxicities, that's quite unique.
Well, we've covered a lot here in the last few minutes, covered the entire bladder cancer paradigm from medical oncologist and urologist standpoint. Sia, Karine, thank you so much for going over this current standard of care options in bladder cancer. For our listeners, let us go over a quick recap.
In this discussion with Dr. Karine Tawagi, a medical oncologist, and Dr. Sia Daneshmand, a urologist, we've covered the current landscape of bladder cancer. We had a chance to focus on growing options in non-muscle invasive space as our patients continue to ask for us to do better than just radical cystectomy.
Then, we also had a chance to discuss localized muscle invasive bladder cancer and our options for including current role of immunotherapy in adjuvant settings. We then covered the new standard of care, which is EV with Pembro, along with options such as erdafitinib and sacituzumab for metastatic disease. Thank you for joining us. Make sure to check out our renal cell cancer discussion with Dr. Monty Paul and prostate cancer discussion with Dr. Raina McKay. We are the Oncology Brothers.